So our last speaker in this session is Dr. Mark Miller. Mark is an assistant clinical professor in the Department of Pediatrics and Internal Medicine at the University of California at San Francisco. And he also co-directs the UCSF Pediatric Environmental Health Specialty Unit, so PSHU, many of you have heard about, and is the director of the Children's Environmental Health Program at the California Environmental Protection Agency. And so we're going to take a deeper dive on a particular type of cancer that is alarming in terms of its increase in incidence. And I think Mark's research on looking at the kind of systemic review of the literature kind of suggests we're ready for action. We're ready to do something about prevention related to this disease. So with that, Mark, I'll let you go.
Well, thank you so much for inviting me. It's a pleasure to be here. I have no particular financial disclosures to make, and acknowledge my coworkers and our funding for particularly the Center for Integrative Research on Childhood Leukemia and the Environment. That's at UC Berkeley. I've got about 20 years of working in this area. I put this first slide up with the idea that we can do stuff, and we can do prevention. I talk to the clinical world a lot, and they're not used to thinking about this. This is public health. There's another world, you know. But this is a slide that's looks at the reduction in air pollution in the Los Angeles Basin, particulate matter, ozone, NOx, over a 20-year period from 1990 to 2010. 3 separate studies looked at groups of young children and their lung function growth during that time period from about 8 years to 13 years or more or less. So one group was earlier in that time period, one in the middle, one in the later period. And if you look at those 3 different groups, from the first to the last group, there was a reduction about in half of the number of children that had significantly reduced lung function, less than 80% of what we would predict it should be. So we can do stuff like that. What we know about childhood leukemia, one thing that's important, some people have mentioned windows of susceptibility. We know that one of the primary time periods that's a concern is prenatal. We know that because we can look at blood spots of children born that have leukemia and see that the changes, some of the genetic changes in those cells occurred before birth. They didn't get the leukemia until later, but they occur then. Not only that, these changes, one of them is called TEL-AML, and that occurs in maybe 100 times greater number of children at birth than actually go on to have childhood leukemia. So that there has to be not only that, but events after birth that go on to that transformation. So it adds to the discussion that we've been having. This is a multifactorial thing and actually multi-time periods. This is the SEER data for childhood leukemia over a period of about 40 years. And we see maybe a 35% increase in ALL, which is the most common form of childhood leukemia during that time period. We looked in California at the cancer registry data and looked by ethnicity over a period of about 25 years. What we see in the red line that's on the top, first of all, background. Childhood leukemia occurs more commonly in Latino children, but Latino children of Mesoamerican background. So that's well known, and there's some genetic underlying reasons why that occurs. But if we look at this period of 25 years in California, the rate of increase of childhood leukemia is far greater in the Latino children than in the white children. So there's something that leads to the conclusion that there's something environmental. It's not genetics that changed during that time period. This is just to say that all of my thinking about this is related to the general children's environmental health issues that I'm involved with and many others. There's a whole network, pediatric environmental health specialty units. There's the Academy of Pediatrics. There's Children's Environmental Health Network is represented here today. There's a bunch of people that work in various issues related to children and environment. When I got involved in working with Circle, the research team, I came in to work on translation. So one of the issues was, well, what do the clinical world already think about this? So we did a survey, got about 200 responses from our network from our study, which pretty much is all the California cancer providers, a group at Huntsman and Dana-Farber in Boston. So we had these all these people, and we looked at both nurse practitioners, fellows that were working in this area, and attendings. And by and large, they more than half, and sometimes for nurse practitioners, nearly all, said that they felt that that environmental exposures were in fact an important contributor. But when we delve a little more deeply, though almost all of them report getting questions from parents about causes or particular exposures, most of them felt very uncomfortable in discussing that. Well, we know that there's very little environmental health that's in medical education or nursing education. 92%, though, here's the positive, said they would really want to learn more. They want to know more about these issues. They'd like to be able to better deal with those questions. So we have our own study in California that started in the 1990s to look at different issues around risk for childhood leukemia. So one potential risk factor is tobacco. And when you look at it, it turns out that it's mostly related to paternal smoking. And you can look at different time periods. Preconception or very early prenatal exposure seems to be important. Paternal, this is the father smoking, as well as exposure to secondhand smoke in the home, paternal smoking at home. So what you see here is that you really don't see the risk until you add those two time periods combined. Okay? Not only that, it's very important to drill down. It's not one disease. Childhood leukemia, even the different types, is not one disease. There are these genetic differences. This is a very heterogeneous thing. So if you look at one group, which happens to be the most common group of genetically, subtypes of the cells called TEL-AML, which is a particular translocation of your DNA that occurs, now you see well over a twofold increase in that group of cancer when you look at both paternal exposure before the pregnancy and paternal smoking as a young child. Well, because you have to drill down to these kind of very detailed looks at things to really see what the risks are for the highest risk people, we've developed a consortium. This is 23 groups around the world that do this kind of work in looking at the epidemiology and risks for developing childhood cancer. Now we're able to talk about tens of thousands of cases, which is important because this is a very rare disease. Childhood cancer, if you add it all together, is very rare. It's much more difficult to study than adult cancers, which are much more common. But then we're able to look at, so this is looking at maternal exposure to pesticides occupationally during pregnancy and risk for childhood AML, this particular type of cancer. And what you see is the top set of the studies are the group of studies that are in this consortium where we're able to pool data and look at it it's a very powerful way to make sure you're looking at the same things. And it's over a twofold risk if mother was working with pesticides during the pregnancy. But the detractors would say, well, maybe that's just a specialized group you have. What about all the other information that might be out there in the world? And so in this paper, they also separately analyzed all of the other studies that existed that could look at this question outside of the consortium group. And in fact, they show about a 4-fold risk. So now the combined risk is over 3-fold increased risk for exposure to mothers via work to pesticides during pregnancy. Traffic, here's another one. These are the pesticides, traffic, these are related to a variety of children's health issues. Traffic, this study by the CDC group looked at 7 studies and did a meta-analysis to look at that, showed about a 50% increase in childhood leukemia related to exposure to traffic. This shouldn't be a big surprise. One of the things with traffic is the hazardous air pollutants, which include benzene. Benzene is a well-recognized well-recognized leukemiogen in adults. People still want to argue about it in children. Well, a colleague of mine in California did a meta-analysis of all different sources of benzene, studies that looked at it in childhood leukemia. And this is the result, the end result, saying, well, if you add up all of these different studies, it looks like about a 2-fold increase in risk with exposure to any form of benzene. So I put that in as a prelude to talking about paints. Here's paints in childhood ALL. So to AML, we talked about. ALL is the more common form of childhood leukemia. Painting in the household is associated with risk. And then this, we're able to, because it's the CLIC study, try to look at, well, is there a particular window before conception, during pregnancy, or after birth? And you see risks, throughout those time periods. You see more with the oil-based paint use, which has a lot more of these volatile organic compounds and probably benzene related to it. And you see a higher risk, 50 or 60% increase in risk when it's professional use. That may be related to when you have a painter come in when you're pregnant and you're getting the child's room ready to work on the house. They come in and they work all day, every day. That's a higher dose exposure, whereas if you're doing it yourself, you might do one wall 1 week and another wall another week. So at least that's how it works at my house. Home use of pesticide. Again, this is just just to give you some idea. 40% increase across risks for ALL, but also see some risks for AML, the more rare cancer. So I should say, as a background, we've done huge work in addressing treatment of childhood cancer. We now cure 80 to 90% of children diagnosed with cancer. But that is not a reason to, write it off. I mean, prevention is still really important. This is a staggering event for children, families, and communities. So we try to look at the attributable fraction that people have talked about, and this is preliminary, but we've been around it quite a bit. And if you look at traffic, painting, and solvents, and tobacco, and try to add that together, we keep coming up with 10 to 30%, with that being a potential risk factor. So I don't get caught on the numbers. Even if it's 3 or 4 or 5%, that's a significant contribution. So if we can reduce a little bit the risk, that's a big thing. So not only are there risk factors in the causation kind of pathway that we are concerned about, there are things that reduce the risk. Breastfeeding for 6 months or greater reduces the risk by maybe 15%. Being in a large daycare decreases the risk by maybe 20%. That's thought to be related to the immune system in early events priming the immune system that reduce risk. Adequate folate, a good diet, folic acid, prenatal vitamins is a reduction in risk, particularly if you look at groups that might have a poorer diet. So this is a CLIC study around the world. When you look at potential diet-related factors, looking at lower education around the world is one way is a surrogate for looking at diet. And you can see, if you have a low level of education and you took a vitamin, then you have maybe almost a 30% reduction in risk. If you specifically took folic acid, maybe a 50% reduction in risk. So that's important. What does the American Cancer Society say? Because this is where we have to work with, is no known way to prevent most childhood cancers. There's no known risk factors that children are associated with. So that's a big order to try to move the world when that's what the common knowledge is. But I would like to compare that to sudden infant death syndrome, which back in the early 1990s, we had much less information than I've just presented for a number of these risk factors. And it was presented to the Academy of Pediatrics that we should have a back to sleep program because there was some evidence that children sleeping on their back were at less risk. And there was a number of scientists that said, oh, no, you shouldn't. We don't know actually what causes these. There's limitations to these studies, and there are not a lot of cohort studies, and we don't know what the mechanism is. Well, there's a graph of the decrease. The back to sleep campaign won the day, and we saw a reduction in SIDS in the United States of about 50%. If we look to this day, we still don't really know all the mechanisms related to SIDS. So how long do we want to wait before we take some action on some of these things? And then I want to add to that the idea that we should be doing these things anyway. And we are trying to, but this cancer is yet another point. Pesticides are related to neurodevelopmental problems, asthma, tobacco, I don't even have to say, traffic, lung problems, folate, neural tube defects, autism, it appears, and breastfeeding we want to support. So what have we done? We're working with clinicians and people in training. We have the Story of Health. There's some brochures up on the table about it, and it looks at, takes a family reunion and follows different children through. There's a story that's about childhood leukemia, follows this child from diagnosis, and all these factors that you can learn about within it, including embedded videos. I'd also like to mention the Pediatric Environmental Health Toolkit. This is something that a pediatrician, a nurse, a public health person, or others might use how do you discuss some of these things? What's an issue? How do you find out what are some preventive factors? And it's an online app that you can use. There's the address. If you look at the environmental hazards, you can look at a list of them and click on one, and then you have these little tabs. What is this all about? How do you get exposed? What are the health effects? And what are some preventive measures that people could take? We work with communities and develop things like infographics that we use with, for example, we've identified Latino population is important. We work with promotores de salud who are lay health workers, and we can provide them then with this information. Point out the bottom, start protecting your children's health before they are conceived. We have a program improving environmental health literacy of young adults, because we want to get people before they have children. You got to start early. So this is a shadow puppet video that we did, is available. All this online through the Circle program, a comic book. These are materials that our promotores and others can use. Then the last thing, there are things that people can do themselves. Of course, this is something that we have to work on as a community. You can't really deal with the underlying problems unless you deal with it systemically and what we're exposing people to just through the course of the day. We were able to work with NCI to get some change. This is a little, there's disclaimers associated with it, but at least now, instead of saying, we don't really know, studies are mixed, it says, you know, some types of leukemia have been associated with fathers tobacco smoking, pesticides in the home and at the workplace, solvents and outdoor air pollution and brain tumors, pesticides, and, you know, so there's some mention in this fact sheet that the NCI has that people can at least acknowledge that maybe this is a concern. Last thoughts. So, you know, it's important for people working this area to follow this literature, to advocate with the state, federal authorities on policy. We need to increase the funding for factors that look at risk that might be able to be reduced. And I think it's important to tie children's environmental health to the specific childhood cancer risk. This is all one and the same. Thank you.